Okay, I think we are good to go. Good morning, everyone. Please, if you can hear me, I just need someone to just confirm that you can hear me clearly.
Yeah,
Perfect.
morning.
Thank you. Good morning. So, today we are going to be covering ENT, and ENT is quite a small area, but again, ENT is wide. And I know why I've said that. Um, I want to specially welcome all of you to this morning's ENT teaching session. My name is Olale Kongungbemi, and I've decided to use a different method of teaching, which is not new, but we've got different methods of teaching, as you guys know. Some of you who attended the cardiology teaching would have seen that we used the teaching mocks teaching style for the first session. Well, today we're going to be using what we call audio points or audio notes, and the aim is so that we can cover a lot. We have about 250 ENT points to cover, and it will only be fair if we can do as much as that. In ENT, the questions are usually simple, and I don't want anyone to fail one single question in ENT. Just one question in ENT. And I don't know how many of you followed the last AKT trend, but if you follow the last AKT trend, you would notice that if you were scoring an average of 7 over 10 in the different subspecialties, you won't make it. You would have failed the exam. So anybody that is scoring 7 in cardiology, 6 in ENT, 7 in ophthalmology, that person would have failed the last AKT. And this is the trend towards which the AKT is going. You need to be scoring above 8. And it won't be fair to yourself. I mean, there are things like there are some areas that are a bit technical. And I can understand candidates getting 7 or 6. But in ENT, this is an area where you can get 10 over 10. This is an area where you need to target at least 9 over 10. And so I just thought it to be fair to everyone that we cover as much points as possible and make it simple. Now, if you have been following this class, I've been begging everyone to avoid jargons. Jargons is the reason why candidates fail the AKT. Let me spend a minute to talk about jargons, please, because I probably have not talked about jargons to you guys. Jargons is actually when you make 50 pages of ENT notes and you cannot read it. That's jargons, my friends. Jargons is when you are studying without focus. You have no direction. You're studying anyhow. That's jargons, my friends. Jargons is when you read 200 pages of nice guidelines and you cannot remember it in the exam. That is jargons. That's what we mean by jargons. Jargons is when you've paid for several question banks, you've solved thousands of questions, but you do not understand the principles behind the questions you've solved. That is jargons. That is the wrongest way to study, my friends. I want you to avoid jargons, whether it's ENT, whether it's cardiology, whether it's statistics. Please don't make 80 pages of notes. If you've not heard me say this before, you're hearing it now. You won't be able to read it. It is jargons. And so today, what I've done is I've tried to avoid jargons from the ENT notes. In fact, what I'm going to be doing today is audio points. Audio points. And so your notes are ready. Everything I'm going to say today is going to be sent to your emails. You're going to get it as a PDF document. You're also going to get the picture slides. You're going to get everything about ENT. But I just want you to concentrate today. There have been a research done, and the research shows that if you see pictures, you get quite a lot. As you know, pictures spell more than 1,000 words. But again, if you listen with full concentration, you can get quite a lot. So what I've just done today is I will be giving you the points in bits. I'll be breaking it down very simple. Again, I'll be repeating things. You'll be hearing things under another session. So for example, when we are talking about one session, I may repeat it under another session because it cuts across multiple sessions, and that repetition also helps. So let's go right into it today. We are going to be having a couple of breaks as well because it's going to be a lot that we're going to be doing today. But let's try and see what we can do, and let's try and finish within our allotted time. So we're going to be starting with epistaxis. Epistaxis is high yield. Yesterday I was seeing a patient. So we do something called acute prescription. So patients say, "Oh, doctor, I want this medication." That's what we call an acute prescription in the practice. And this patient had put in that he wants metronidazole gel. Metronidazole gel. So I looked at his notes and found out that in the past he's had acne rosacea, and he's had it a number of times. In fact, this year he has been prescribed twice. So I said I'll give him. It sounded very reasonable, but I just said I should phone him just to touch base with him. And when I phoned him, I asked him a few questions. He told me that, well, doctor, this medication doesn't work, but I've got no choice. This thing is on my face, and in fact, because of this, I don't come out, and so I just need to keep trying it. And I noticed he's been trying it for 2 years, so I refuse to prescribe it. Please do not prescribe a medication that doesn't work just because the specialist has put a patient on it. Don't do that. Review your medication from time to time. Do not prescribe a medication for a patient just because the patient has been on it for 17 years. If it's no longer working, review it. If it was on eplerenone, it's no longer working for heart failure, change to spironolactone. Change the medication. Anyone that is not working, change the medication. Review the medication. Look at side effects. Look at contraindications. So I told this patient, come in, let me see this acne rosacea on your face. Let me see this rosacea you're discussing about. He came in the afternoon that day, and as he entered through the door, I could see that this was rhinophyma. What am I talking about, friends? Wrong diagnosis, the treatment can never be correct. You can never give a patient a treatment of acne rosacea for rhinophyma. It won't work, my friends. And so this is where I start today with epistaxis. Please, I'm going to focus more on presentation and then end up in management. You need to first know the answer to the question. You need to know what the question is talking about before you can even get the answer of the question. You need to know what they are discussing in the question for you to be able to say, yes, this is the answer to the question. So today we're going to be looking at epistaxis, and epistaxis is high yield in your exam. It can come in different form. It can come anyhow. That's what I'll say. It can come in any way, and you must be ready for it in whatever way it comes. So one of the popular questions in the exam is how to manage epistaxis. You see a patient is rushed to the A&E. The patient has been bleeding from the nose for the last 5 minutes, is still bleeding from the nose. Well, when you discharge that patient, the best advice to give is when this happens again, they should pinch the soft area of the nose, that's the cartilaginous area of the nose, for at least 20 minutes. That is the guideline, my friends. Pinch for 20 minutes. You will see some answers. They will say the patient should lie down and so that the blood can drip into their pharynx or their throat. That's all wrong. Patient should be seated forward with mouth open. Sit forward with mouth open. Pinch the soft part of the nose. The soft part, not the firm, the soft part of the nose for 20 minutes. That will be the answer of that question if you saw it in your exam. Now, in terms of, now that we start with management, packing is a type of management for epistaxis. Using cautery is a type of management for epistaxis. Some people will use what we call surgical ligation. So what they do is they look out for the feeding artery and they ligate it so that it stops bleeding. That is a treatment in the AKT. In the GP practice, your commonest treatment will be Herceptin. Herceptin is a medication that is used to take out nasal carriages, usually caused by Staphylococcus. So one of the reasons why patients will bleed is because they have nasal carriages, and that needs to be cleared away. Now, this is the AKT question. The answer will never be Herceptin if the patient has peanut allergies. What am I saying? In the AKT, they will give you a lengthy question. They will say the patient has had it just once. It stopped after 5 minutes. What will be the best primary care management? Option A will be Herceptin. But if you have not read on that in the third paragraph of that question that the patient is known to have peanut allergies, you fail that question. Herceptin peanut allergies, no. You cannot give Herceptin to a patient with peanut allergies, please. Now, that's for your AKT. In real life, is a GMC problem. I once was working in the A&E and the doctor prescribed Herceptin for the patient home. 2 days later, the patient was back with a serious anaphylactic reaction. This is what Herceptin can do. Of course, there was a complaint afterwards. So please ask your patient, if it's not on the notes, even if you want to prescribe, do you have peanut allergy? If they say no, then that's fine. Have you eaten peanuts before? That's a simple way to ask. They say yes, we've eaten peanuts, there's no problem, prescribe Herceptin. That is allowed. Now, this is just for you to identify your question in the exam. If you see a patient who has been nose picking, a dementia patient in the exam, nose picking, that is one of the commonest causes of epistaxis in the exam, even in real life. A child that is having epistaxis, please you can think foreign body, suspect upper respiratory tract infection, suspect things like allergic rhinitis. Those will be common causes of epistaxis in children and even in adults as well. Okay, so let me give you some scenarios. I've got this patient is in the AKT. They give you a 24-year-old female. This female, they just wrote 2 lines about it. The question has a lot of blood tests in it. There's a full blood count result. There's U's and E's. There's LFTs. There's thyroid function test. You skim through it very quickly. You see that everything is normal. Your eyes catch something. What does your eyes catch? Low platelet. Platelet was 80 in the exam. Platelet was 120 in the exam. Your answer is idiopathic thrombocytopenic purpura. That is why the patient has epistaxis. By the way, that topic is high yield. You need to know everything about ITP. First line, oral prednisolone will be the first line treatment. If you do not see oral prednisolone in your question, please think immunoglobulins. If you search your question, there's no immunoglobulins, there's no oral prednisolone, the answer is plenectomy, my friends. Okay, how about this patient that has, on the blood test, you can see prolonged bleeding time and prolonged APTT. I know all of you know the answer is von Willebrand disease. So what von Willebrand disease is a cause of epistaxis in children. Don't fail the question. Hemophilia will be usually bleeding into enclosed spaces. Von Willebrand disease, prolonged BT, prolonged APTT. How about you're seeing a patient with epistaxis? This coming through one nose. The patient also has ear pain. What are you doing if you don't choose nasopharyngeal cancer? One nose bleed is a red flag. One nose blockage with polyps, red flag. Anything one nose in the AKT, don't wait for them to tell you it is a cancer. It is a cancer until proven otherwise. Sometimes they will help you. They will say the man is Chinese. That is nasopharyngeal cancer, my friends. Pick your answer and move on. Okay, you seen this patient. The patient is known to have sinusitis. He's been having shortness of breath for a few years, and now he's having epistaxis. Someone has just echoed the answer. The answer is Wegener's. My friend, if you are looking for Wegener's in your exam, you will not see it. The name has been changed to granulomatosis with polyangiitis. So granulomatosis with polyangiitis is C ANCA. Chalk Strauss is P ANCA. Chalk Strauss is P ANCA. Wegener's is C ANCA. Okay, you've seen this question. This question says the patient has recurrent nosebleeds. You saw an examination, multiple telangiectasia. Multiple telangiectasia. You can see telangiectasia on the lips. There's telangiectasia on the oral cavity. They've given you the answer. They don't have to spell everything out before you start to, and you don't have to read the whole question. This is the 10 seconds rule, my friends. Pick the clincher, move on. It is HHT. HHT is hereditary hemorrhagic telangiectasia. Assuming we are not doing ENT today, I would give you the question in a different way. A patient presenting with a family history and rectal bleeding. What are you thinking? It is an autosomal dominant condition. That is hereditary hemorrhagic telangiectasia. You need to be super good. How do you become good? You need to be familiar with every way every topic can come. And today you see that I've changed the style. I'm not teaching you hereditary hemorrhagic telangiectasia as a slide, and then I'll put all the 10 points about hereditary hemorrhagic telangiectasia. No, I'm teaching it in different ways where it can fall and how it can come. I'm going deep into the roots of the topics. How would you see it in the exam? This is how you will see it: recurrent nosebleeds with, on examination, multiple telangiectasia on the lips and oral cavity. You've got your answers, my friend. Okay, assuming you saw, I asked a candidate the other day about epistaxis in a 2-year-old child. The candidate said, well, first thing, I'll do bloods because I want to rule out von Willebrand. I want to make sure it's not a bleeding disorder. I want to make sure it's not Christmas factor. If the bloods come out to be normal, I can reassure. You failed that question, my friend. Epistaxis in the 2-year-old, guideline, refer. You are not supposed to treat that patient. It could be something more serious. Some of the investigations you cannot do in primary care. Refer to the pediatricians. Do not do their job for them. Make your life easy. Epistaxis 2-year-old, refer. Epistaxis 2-year-old, refer. I think I've done some justice to epistaxis because we have quite a lot to do. What I've done is to exclude jargons. I could have simply come and given you guys 2 pages of epistaxis, but no, I've just sieved out the high yield stuff. Those are the things you need for your exam. So let's move away from epistaxis. Let's go to something else. Let's go to vertigo.